I'm waiting for it now.
I don't even know why I'm nervous for tomorrow's thing. I know this shit.
You're live. Just so you know.
Oh, okay. Oh, now I'm live.
I don't see him. I just see this thing. Yeah, there it
We
goes.
got 6 people now. See, it's it's good.
We're good?
Yeah, people are coming on. You got it, Nikki?
Yeah, it sounds good on this.
Great. Let's wait for you guys. We've got 7 people on now. Yeah, that's good. 9 o'clock says, hey, Dr. Rutland.
What's up, Brian? All right, guys. We're back on Medicine Deconstruct live on YouTube. I don't do very many of these, but when I do, I like to do it in a thing like this. I know everybody is worried about SARS CoV-2 and COVID-19. I'm just as worried. I will say that cases are on the rise. They are. And I think we had 153,000 so far new cases today. But hope seems to be on the way. And when I'm talking hope, I am talking therapies. I'm also talking vaccines. We've talked about SARS CoV-2 before, and I always like to review it before I really get into the immunology because I think it's important to review. SARS CoV-2 is a coronavirus, and it's a coronavirus that has a very virulent protein on its membrane called the spike protein. There's an S1 unit and there's an S2 unit, right? So it's like one subunit, 2 subunits. The S1 unit is responsible for binding to the ACE2R on our epithelial cells and our endothelial cells. And then the S2 unit is responsible for fusing the membranes and allowing the SARS-CoV-2 genome to get on the inside of our cells. As a result of that binding, it starts an inflammatory cascade that not only leads to recruitment of the white blood cells to that specific area, but it also leads to coagulation abnormalities, and people tend to have a thicker blood, and it can lead to blood clots, platelet aggregation. So as a result of that, you can get really sick and you develop COVID-19, which is the disease caused by SARS-CoV-2. Now, as I've always said, there are 7 different coronaviruses that infect humans in the history of the world, essentially. 4 of those coronaviruses tend to infect us every single year and cause the common cold in about 30% of adults. And if you guys have heard me before, and since about February, March, I've always asked this question of, well, maybe that's why kids aren't getting COVID-19 as severely because they already have some level of protection because they're always getting sick anyways, right? And so perhaps this is now, just because I want to be accurate about my computer here, just to remember, but.
Oh, wait, hold on. I lost this. Did you get the little thing from Roy's phone?
What?
Did you get the thing from Roy's phone?
No.
Here, we need that.
Okay. So we're off.
That says we're unstable. Let's see. Oh, you're back. Go get that thing from the
Where
phone.
is it?
The phone's right there. It's on the back of the phone. Sorry, guys. So we're gonna get back on here. No, the phone straight ahead, right behind you. That phone. She says it's on the back of that phone.
Yeah, that thing helps, I think. All right, so continue on.
All right.
Go back on.
So to get this right, what I wanted to tell you is that out of the 4 coronaviruses that we talk about, the 4, and we're talking OC43, NL63, 229E, and HKU1. 2 of those coronaviruses are very similar to SARS-CoV-2. The other ones are similar to SARS-CoV-2 as well, but just not as similar as 2 of them. And so when you look at this study, which looked at antibodies that were developed in children and seeing if the antibodies that they had towards a coronavirus would neutralize SARS-CoV-2, it actually turned out that a lot of the adolescents and children had these antibodies. And so it was very, very telling. And it at least got me thinking, right? And the two beta coronaviruses that the spike protein on SARS CoV-2 is pretty much homologous to are OC43 and HKU1. And so what it told me was that, I don't know why I think this way. And maybe I'm totally crazy, and maybe Dr. Fauci will disagree with my thought process here. But my thought process has always been, why not inoculate people with a non-virulent coronavirus to see if that helps stimulate some immunity and offer some protection towards SARS CoV-2? Because it seems to, in this population of adolescents and kids, so I never understood why we didn't think about that for us, right? For us that maybe don't have children or don't have that exposure to coronaviruses. Again, and another one of my thoughts has always been, well, teachers and parents of those school-age children are probably more likely to have those antibodies as well. And perhaps that's why the older population is getting more sick, because they're so far removed from that exposure. But then again, you think about grandparents that take care of their grandkids, and maybe it depends on how often they're taking care of them. And we all try to protect our grandparents and our parents by not allowing our kids to be around them when our kids are sick, because you don't want them to get sick, which I understand. But again, all of this goes along with the immunology that we're now seeing in all of these studies, which is kids and adolescents are somewhat protected, likely because of the presence of these antibodies. Now, the other thing you have to understand is that when you look at antibody protection as it relates to SARS-CoV-2, and you're looking at vaccines, what we have to understand is that there are 5 different types of antibodies that reside within your body that kind of float around your bloodstream. There's IgA, IgM, IgG, IgE, and IgD. No one really knows what IgD does, but IgE is responsible kind of for allergy. In the United States, at least in the Western world, it's really responsible for allergy. It binds to the basophils, eosinophils, mast cells, and other cells. And then IgA has 2 kind of really subdivisions, IgA1 and IgA2. And it's responsible for protecting the upper airway, like the mucosal layer. So like your nasal epithelium, your throat, your mouth. And then you have IgG, and there's 4 different subtypes of IgG, IgG1, 2, 3, 4. You've heard about them in autoimmune disease, I'm sure. But IgG1 is kind of the most abundant antibody that floats around in your bloodstream and protects kind of like your system. So when you're giving vaccines, and there's many different types of vaccines, we'll go through that in a second. But when you're giving vaccines, and if you inject it in your skin or your arm, what you're developing is an IgG1 type of antibody. So you're protecting almost your system and your lung to a certain extent. So your lower respiratory tract and your system, right? And IgA doesn't really develop, but you can see IgA antibodies in some of these patients that have developed some immunity towards SARS-CoV-2 as a result of being exposed to other coronaviruses. So that's kind of the difference there with the vaccine, is you're generating that IgG1 type of antibody as opposed to that IgA. Like, you're not going to develop that IgA. So theoretically speaking, people can still get infected up in here, and you can probably still have symptoms up in here. It actually made me think of something today. And again, I'm just kind of throwing out thoughts right now. I'm not saying that this is backed up by evidence, at least this right I'm about to say right now. A lot of people have said that they get sick when they get the flu vaccine, right? They get the sniffles, or they get a headache, or they feel like they have a upper respiratory infection. Well, the flu vaccine is an injection. So I'm wondering, if since you're only generating IgG1, you're not really protecting your nasal area anyway, so you're probably vulnerable anyways. I don't know. So maybe that's why you get sick. Or the other thing is, like, you're supposed to get sick when you get a vaccine, at least a little bit, because it tells me that your inflammatory response is working. And when you look at some of the volunteers that have received the SARS-CoV-2 vaccine, whether it's an mRNA vaccine or an inactivated vaccine, some of them explaining their side effects. Like one person, I think today, said that they felt like they had a hangover, like a really bad hangover. So they had these like body aches. Some have had fever. Again, for me, that kind of tells me that the immune system's at work. Not that anything bad can happen from it, but it tells me that the immune system is at work. So it's just interesting. And I want people to understand that, listen, like, people say things like, oh, I want my kid to get natural immunity, so I rub them in dirt and let them go outside and let them get sick. I mean, like, I understand that and I get that, but vaccines are important. And I understand the ingredients, and I understand that some people are nervous. I want you guys all to know that the initial study by Wakefield that linked vaccines to autism was completely removed from the medical literature because it had no validity whatsoever. And it turned out this guy worked for a company that was trying to do that. But it doesn't matter. I understand your concern with that. But I think in this day and age with the pandemic, when the only defense we have right now is masking and being hygienic and social distancing, I think that vaccine development is extremely important. A lot of people have talked about, well, normally it takes 15 years to develop a vaccine. That's absolutely true. But the reason it takes that long, the main reason, is because of the financial investment. So when you're developing a vaccine, you want to have a disease that is prevalent. You want to have a disease that's going to benefit from the existence of this vaccine. And you also want to be able to make the money back that you invest in the development of the vaccine if you're a company that develops vaccines. That's like the major reason as to why it takes 15 years. It's not because of safety. It's not that. What you have to understand with Operation Warp Speed is that we're able to provide and perform several of these protocols simultaneously. So you can have a phase 1 and a phase 2. Normally it's phase 1, and then it's phase 2, and then it's phase 3. What you're noticing is that you're seeing phase 1/2 because we're performing a lot of these phases together. The vaccines that you've heard about recently, you've heard about the Pfizer BioNTech mRNA vaccine. An mRNA vaccine is a type of vaccine that encodes for a certain protein, right? So it's going to encode for the spike protein in this instance, right? So if you encode for the spike protein and you deliver this vaccine to our immune system and our immune system sees it, it's going to be able to develop an inflammatory response against the spike protein. And immunologically, CD4 cells develop and antibodies develop. And what they're saying is that the vaccine is 90% effective. So you get one shot, 3 weeks later, you get another shot, and then a week later, you measure the immunology, you measure the immunity, the amount of response you get. And what they're saying is 90% of people are getting a response. So developing those CD4 cells or developing those antibodies towards the spike protein. So that's positive. And at least so far from an mRNA vaccine, which, by the way, has never been approved in the history of the world, no mRNA vaccine has ever been approved. We're starting to see that perhaps they are safe, and they seem to be safe. And the other thing that people always say is they say, well, it's so fast, you developed it so quickly. And we just talked about that. But the other thing I want to bring up is that in 2003, when SARS CoV-1, the pandemic or the epidemic started in China, it was really an epidemic, never became a pandemic. It was about 8,000, 9,000 people that got it. They started to work on that vaccine. And they had developed a vaccine that had, I think, gone through phase 1 trials. So the science for developing a vaccine for a coronavirus was already there. There was already a pathway that had been created. So they just built on that pathway, and they were able to start not from the beginning, but somewhat in the middle, so to speak. So they were able to take that science and apply it and move it forward. So don't think that this just came out of nowhere, right? It's not like it's a brand new virus that we've never seen before. This is a coronavirus. And not only that, but it's a coronavirus that had already been going on or had already been developed for enough for an epidemic.
Question.
Yeah.
Brian Fox. You said that you are seeing that mRNA vaccines may actually be safe. Why would they be unsafe?
That's a good question. Why would they be unsafe? Because it's a new concept of vaccination that has never been approved. So you always want to worry about that, right? When you're instituting a different type of molecule. So these mRNA vaccines basically are traveling through our body through these lipid nanoparticles that we call. So surrounded by a whole bunch of fat droplets, and then you inject it, and then it has to diffuse across cell membranes to get exposed to the immune system and such. So you don't really know what's going to happen when you're instituting these new vaccines because it's a different concept than an inactivated vaccine, right? Normally we have inactivated vaccine like influenza or pieces of vaccine. So it's just a different concept. So it's not that it's unsafe, and it hasn't caused anybody to die. There was a kid in Brazil, a healthcare worker actually, that participated in one of the vaccine trials. I think it was either this one or one of the adenovirus vectors. And this healthcare worker died. They contracted COVID and died. But it turns out, and this is what I'm hearing and reading, that kid who was randomized actually didn't get the vaccine. He was randomized to placebo. So the question is, would the vaccine have saved his life? And he would have not gotten it. So that's something that you're probably going to see come up in the next few days. So they're good questions. And these are all great questions to have. And I guess the way that I counter these questions, the way I think about these questions are when I go outside or when I go to the grocery store, or even in my office, people are smoking. That's unsafe. I'm not saying smoke. I'm just saying that's unsafe. People are driving cars. Vaccines are safer than driving cars. There are people that die every few minutes in a car crash, in a car accident. I got to go to the hospital after this and go round on patients. I get in a car accident, but I'm still up every morning and I'm still driving. So I understand the argument and I get it because you're not in control, right? You get something injected and you're not in control of what happens. I understand. But obviously, we're not in control of this virus. Obviously, this pandemic is out of control. And I understand the argument of people saying that, the virus doesn't affect that many people and not that many people get sick. I get all that. I understand. But it's significant enough to increase the burden on us in the hospital, right? We've got a lot of patients that are that are really, really sick in the hospital, a couple that I got to go see right now. And so that is the reason why these vaccines and this vaccine development is extremely important. A new medicine was approved for emergency use on Monday or Tuesday, a monoclonal antibody that acts at the receptor binding domain of the spike protein called benvalumab or something like that. It's the Eli Lilly antibody. And it's given to outpatients that have COVID-19, outpatients with risk factors. When you look at the data, it reduced hospitalizations by 5%, which gives you a number needed to treat around 20, which is awesome, right? It reduced hospitalizations and ER visits. The question is, how are you going to institute this logistically? Who are you going to give it to? Where are you going to give it? Because you want to give it in a clinical setting. But I'm so excited about this. Like, this is something that I truly believe in because monoclonal antibodies basically neutralize the infection, right? So it neutralizes the amount of virus that can bind to other cells and cause infection, right? And increase that inflammatory response. So if you are positive for SARS CoV-2 and you get this monoclonal antibody, perhaps your immune system won't be as activated as much, but you will also have the ability to develop some immunity towards it. You're getting a little bit of virus. You're inhibiting the rest of the virus, its ability to bind to your cells. So you're developing immunity while calming down disease, which I think is great. Is there another question?
Yeah, there's two questions from Dr. Q. He says, do you think the majority of the population will take the COVID-19, I think the vaccine? And what's your opinion about kids going back to school during the next 6 weeks? And then unrelated to this topic, but and he says it's
Bamlanivimab, it's the monoclonal antibody.
Because they always have the NAB at the end. Mm-hmm. And then what's your opinion on legalizing marijuana? Do you think we should believe it? We should have marijuana in society than alcohol. It would be better to have marijuana than alcohol.
Well, isn't marijuana already legal in some states? Half the states went green. So I mean, like, I don't know. I don't smoke weed. I got friends that smoke weed. I got no problem really with them smoking marijuana. I tell them they shouldn't, especially if they have conditions such as asthma or emphysema or anything that leads to inflammation and can make them worse. But I understand why people do it. I understand the endocannabinoid system and the benefits that it has on the body, on the immune system, and on the mind. But it's not something I endorse, but I can't control what people do, right? So in terms of comparing it to alcohol, I mean, they both cause your brain to be altered, right, in such a way that can be negative if it's high amounts of that product, of said product. So just kind of, I'm not going to compare the two. Like, I wouldn't say like alcohol's worse for you and kills more people. I mean, maybe it probably does statistically, I'd guess. So it's, again, in the interest of me being a pulmonologist, I would say don't smoke marijuana. Don't smoke it. It's going to hurt your lungs. We know that. The other question was about children going back to school. Such a tough question. Such a tough question. I do think that we're beginning to see negative effects of kids being at home, but I also understand that kids going to school means that more than likely they can get the virus. I just had a friend who just emailed me and said that like his child is positive for SARS CoV-2, so he's quarantining for 2 weeks. He's doing fine, but his child was positive. So it's clear that kids are bringing it home to their parents. Again, I just think we need better ideas. I just think that getting people sick with other coronaviruses might be a solution. I'm dead serious about that. That's just what I think. What's the what was the other question?
Oh, here's some other ones. You mentioned developing immunity to the spike protein. Do you think this immunity could be active against other viruses that also use a similar spike protein on the membrane, i.e. Ebola virus? And what is your opinion? He's asking questions about amphetamines and Adderall, but and then what's the future look like in terms of COVID-19 in the wintertime along with the holidays?
What's up?
Yeah, but since we only have a few minutes, let's maybe wrap it up with this idea. I think this is an interesting question here. You mentioned developing immunity to spike protein. Do you think immunity could be active against other viruses that also use a similar spike protein on their membrane, i.e. Ebola virus?
I don't think Ebola virus has the spike protein. I just have to look it up real quick. I have my computer here just to remind myself what type of virus it is. So Ebola virus causes hemorrhagic fever, but it is let me see here. It's an RNA virus. It's a single-stranded RNA virus, which is similar. Let me see the structure of it. Yeah, the Ebola virus doesn't have the spike protein. It's a different type of virus. Its structural proteins are the VP24 and VP35. So receptors within the cell's cytosol are going to bind some of these structural proteins. Now, there may be a protein that's homologous to the spike protein, but generally speaking, you can get some cross reaction with antibodies, but antibodies are pretty specific for a specific receptor. So just because you're immunized against SARS CoV-2, it may mean that you're less likely to get these other coronaviruses, right? The other 6, but you're not less likely to get a different type of virus.
Right. Okay. And then we'll just give you one last one. Oh, do you want to go over your shoes you're wearing?
Oh, today I got on the Lucky Green Air Jordan 1s. All right. They look a lot better in person than they do in on the screen on the computer. They got this little flap here, which is nice.
If you hold them up, like cross your knee over and cross your leg. Let's see.
These are them today.
There we go. That's nice. Point your toe. We'll get him. There you go.
Point your toe like that bigger. Yeah.
There we go. That looks really good.
Fresh.
These are the shoes today.
Fire shoes. You got a little fire.
And again, I think for me, shoes are just like a positive outlet. I mean, like during the pandemic right now, there are things that you want to look forward to. Again, there's not very many things that you get to do, but like I look forward to wearing a pair of shoes. You know, I look forward to putting something on my foot that allows me to be myself. And that's what shoes do for me, right? I'm not an extremely confident person in terms of all this medicine stuff. But shoes, at least when I put them on, I feel a lot more confident, where I begin to not care of others' opinions of me. So, you know, I'm a mechanism guy. I've been ridiculed for being a mechanism guy, but that's my thing.
Blowing up.
I am blowing up. All these coronavirus questions. Anyway, look, I appreciate you guys being here on Medicine Deconstructed. I appreciate you guys entering the living room. I appreciate going live on YouTube. I really do hope you guys enjoy these lives. I enjoy the lives. I was able to talk about the monoclonal antibody therapy, which is effective. I was able to talk about vaccine development a little bit. Told you about the mRNA vaccines. There's also adenovirus vectors and inactivated vaccine, which they're giving the Chinese soldiers. They all seem to generate immunity, and they all seem to be relatively safe. They're all safe, right? There's been a couple of adverse events that you guys have heard about. Nothing crazy, nothing serious. There's been no serious adverse events. The one event that we did hear about the unfortunate healthcare worker, that healthcare worker looks like got the placebo and didn't get the vaccine. I want you guys to know that another paper came out this week that shows that testing for T cell activity against the virus is probably better than testing for antibodies, right? 8 times better, actually, which is a good thing as well. So we're getting there. Cases are on the rise, so definitely wear your mask. Definitely social distance when you can. Definitely wash your hands. As far as a shutdown of the country, I don't know if it's imminent or not. I think we've gotten to the point where, we got to do something with the rising hospitalizations. Do I think shutting down the country is going to work? I mean, maybe, but I also think if people were compliant, we don't have to shut the country down. This thing is real. All right. I want everybody to know that. So these are the things that I, believe. Hopefully a vaccine is on its way, and hopefully we find a way to distribute the monoclonal antibody effectively. I hope you guys all have a good evening. I appreciate you being here. I'm just trying to arm you guys with information. And this Friday, I've given you more ammunition with COVID and pregnancy, and now with this live. And next Friday will be another episode of Medicine Deconstructed. I hope to see you there. You guys all take care.
Yay.